Well, we can get started. Again, this is recorded, so if you missed the first part, hopefully you'll be able to see it later. But Tom, thanks again for inviting me, and thanks to the Facial Pain Association. My name is Mian, and I'm a surgeon, neurosurgeon in Denver with a particular focus on facial pain. And what I wanted to cover today was a little bit about both some of the traditional surgeries we have for TN, and then a variety of other options we have if those haven't worked, or if it turns out somebody has a condition other than TN. Just a little bit about me. I'll make a quick plug for my website, which is down here in the bottom corner, that has a lot of the content that we'll be discussing today in kind of a patient-friendly and digestible format. And I'll put that link up again at the end.
Okay.
I don't have any disclosures related to the talk today. And so this is kind of my big picture summary. You know, when I meet patients, I really try to emphasize the following points, and I'll try to summarize these again at the end, but important things I want to drive home. So number one, facial pain, we don't have great diagnostic tests for this. And so most of the time, the diagnosis really relies on what you, the patient, tell me. And so that's why you'll see that we'll return to the patient history again and again in this talk. Your description of the pain is the most important factor in me determining which is the appropriate treatment for you. There's a lot of overlap between different facial pain disorders. And importantly, as you'll see today, not all facial pain is TN, trigeminal neuralgia. It's really important to get the correct diagnosis because, as you'll see, the treatments can vary widely depending on what we think the cause is. And many of the forms of facial pain that we'll discuss today are often, not always, but often effectively curable. And so it's really important to distinguish between them to give you the best chance at relief. And the last point I would make is be your own advocate, keep records of your symptoms, and then importantly, find a provider and, if necessary, a surgeon who's willing to listen to you and has experience with a variety of different treatments for facial pain. So I'm going to start with an overview of TN and some of the treatments that we use. And then we're going to spend actually a lot of the time talking about different things that can mimic trigeminal neuralgia and talk a little bit about how we manage those differently. So TN, I'm sure no surprise to you guys. It's characterized by some of the things that you see here. So shocking pain, stabbing pain on one side of the face. Usually patients can tell me the first moment that it started, even if it was years in the past. Patients typically have brief attacks that may last only a few seconds or even a few minutes that stop and start suddenly. And most patients, at least early in the disease, are pain-free between the attacks. So this starts very suddenly and then stops. The typical triggers for the pain are those you see listed. So innocuous stimuli to the face, touch, talking, smiling, chewing, and so on. And generally, the pain respects one or more branches of the trigeminal nerve that you see outlined here. So three branches. One, what we call V1, is up involving the eye and the forehead. V2 is the cheek for the most part, and then V3 is along the jawline going back towards the ear. It turns out that patients experience TN more commonly in the V2 and V3 distributions than in V1, so the lower part of the face. And for reasons we don't understand, the right side is actually more common than the left to be affected. So what causes trigeminal neuralgia? There can be a number of things, but the most common is probably the one you see here, something we call neurovascular conflict. And so, can you guys see my mouse or no?
Yes.
Okay. So this is the trigeminal nerve emerging from the brainstem here. And then off to the side, you can see this other structure that's crossing over it. So that's the nerve. And then some patients we find actually have a blood vessel that's in close proximity to the trigeminal nerve. And we found that this blood vessel can often be irritating and provoke the symptoms of TN with which you guys are familiar. This is what that actually looks like under a microscope. You can see in the center of the screen, the trigeminal nerve passing up and down, and then an artery just to the right of it. And I have a video here that I'll play, and I apologize, the audio may cut out, so I'm going to describe it before I play the video. But you'll see that with each beat of the heart, that artery kind of bangs into the side of the nerve.
That's a great picture.
And so it's this repeated micro trauma to the nerve that we think irritates the nerve. And basically, over time, the nerve starts to conduct innocuous impulses and interpret them as painful. And so just touching the face, the nerve, for reasons we don't really understand, transmits that touch sensation as something very painful. If you move the artery away from the nerve, you can see that there's this discolored area on the nerve. And that's actually the zone that's been irritated, something we sometimes see at surgery. There are other things that can cause trigeminal neuralgia. So one example is multiple sclerosis that causes these plaques in the brain that you can see as these white spots on an MRI scan. And then masses or growths, tumors in the posterior fossa around the trigeminal nerve can cause similar things. This is an example called an epidermoid cyst. But this is only about 15% of the time that we find something like this on an MRI. Most of the time, we don't see any kind of growth or mass. Stroke, just another example of something that can cause TN. And so when a patient is severely affected, the first therapy we actually think about, of course, is medicine. There's a variety of medicines out there for TN. When I'm thinking about operating on a patient, I like to make sure that they've tried the what are called first-line drugs for trigeminal neuralgia before we commit to any kind of operation. I've listed some of the common medicines here, kind of ordered by level of evidence. So the ones you see at the top are drugs that we have the most evidence for, appear to be the most effective, things like Tegretol and Trileptal. Some have even suggested that we use response to Tegretol as a diagnostic criteria for TN. And then some other drugs that are sometimes used, you can see lower down. These are reasonable choices, but I like to make sure that a patient who's considering surgery has at least tried one of the first-line drugs that you see up there. So when should we think about surgery? For me, we think about it whenever a patient has severe or bothersome symptoms after trying 2 or more medications. And again, as I mentioned, I like for one of those medicines to be one of the first-line drugs that you saw listed. We have a variety of surgeries for TN. I'll go through each of these briefly. The first we've already seen, and that's something called a microvascular decompression. This is a procedure in which we try to identify the trigeminal nerve, identify the blood vessel that's compressing it, and then separate the two. This is the most invasive of the surgeries that you'll see that we have for TN, but it's also generally the most effective and the most long-lasting. And it's the only one that doesn't involve damaging the trigeminal nerve. As a result, there's a fairly low rate of facial numbness versus some of these other procedures. So in a microvascular decompression, we do something like what you see here. So in the center of the screen is the trigeminal nerve. There is an offending artery that's right next to it. And we try to separate the two and put a little piece of Teflon padding in between. And so going back to the example I showed you before, again, this is the nerve, here's the artery. And at the end of the operation, looks something like this. I've placed tiny little pledgets of Teflon to serve as a pillow or shock absorber so the nerve is not irritated each time that artery pulsates. The next one I wanted to discuss is something called radiosurgery, or sometimes it's known by the commercial platform that's used. In this case, the technique I use is something called Gamma Knife, but there's others, Cyber Knife, or you might hear this called SRS. They're all the same thing, but this is a procedure that basically delivers a focused dose of radiation just to the nerve. This is done as an outpatient procedure in a single setting. Has pretty good rates of pain control, 80 to 90%, but in some patients, the relief can take up to a couple months. So this procedure doesn't involve any incision at all. This is what the targeting looks like. So this might look familiar. So this is the brainstem, or the part of the brainstem we call the pons. The nerve is coming out forward. I highlighted in yellow here. And we place a target just on the nerve as it emerges from the brainstem and deliver a single dose of radiation. And then we have a series of procedures that I'll refer to collectively as percutaneous rhizotomy. So these are similar to the gamma knife procedure, except they're actually performed with a needle. This is, again, an outpatient procedure. And we insert a needle through the cheek into the face to try to damage the trigeminal nerve from below. There are 3 ways to do it: thermal or radiofrequency, balloon rhizotomy, and finally a glycerol rhizotomy. These typically have a pretty immediate effect, but it's very common for them to cause some facial numbness. The numbness is generally temporary, but in some cases it can persist. This is how the procedure is performed. Again, there's a needle that we insert just lateral to the lips, a little below them, through the cheek. And I try to access this hole in the skull called the foramen ovale. You can see it highlighted here. And there's a predictable location of the trigeminal nerve in the 3 branches relative to that hole. And I can damage it either by heating up the tip of the needle, radiofrequency, by inflating a balloon and crushing the nerve, or by injecting a little bit of glycerol or an alcohol-like substance. This is a procedure I performed recently. An interesting phenomenon that happens is actually, this was a radiofrequency rhizotomy. When you heat up the nerve or damage it, you often see a skin color change in the affected territory. So this is mostly in the V3 territory. It's temporary, but it's an interesting thing that happens when you heat up the nerve, and it will go away in 20, 30 minutes. So I wanted to focus most of today's time on other things that can look or act like trigeminal neuralgia, or things that can cause craniofacial pain, and how we manage them differently. And I think this harkens back to my point in the beginning that it's really important to secure the right diagnosis up front, because the way that we treat some of these other disorders, as you'll see, is very different from the techniques I just showed you. So this is a slide to highlight, I think, for you all. When I meet a patient, these are really the things I focus on. And I would say, of these questions, the first one is actually the most important. So where in the face or the head is the pain? There's a big difference between pain that's behind the ear versus in front of the ear, for example. And then I really try to ask patients what it feels like. I treat pain that's electrical in nature or stabbing in nature very differently than pain, for example, that's burning in nature. When you do have the pain, how long does it last? And then how often do those attacks occur? I have a big distinction, for example, between pain that's constant, that never goes away. There's not a second of the day that you feel relief, versus pain that's intermittent. Are there any triggers for the pain? Was there any surgery or illness that provoked the onset? Has the pain changed over time? And then are there associated symptoms? And associated symptoms would be things like your eye turning red, or your eye tearing, maybe getting a stuffy nose. Those kinds of things are helpful to know if they happen at the same time of an attack. So my suggestion is to keep a detailed journal, and to be able to draw a diagram on a face of where the pain is. This is really helpful for your surgeon. This is an example I have of a patient who kept a detailed calendar of her pain. And you can see that on February 1st, we did her gamma knife procedure. And the days there she had bad pain are highlighted in pink. And you can see, as we talked about before, gamma knife typically has a bit of a delay. But in March, there were fewer days. And then in April, almost no days with pain. And so these kinds of journals are actually quite helpful, both in determining the right treatment for you and then figuring out how you're responding to the treatment. So as I mentioned, of the questions that I highlighted before, the most important to me is, where is the pain in the face? And what I wanted to do is go through a series of other diagnoses that I sometimes see based on where patients typically feel the pain. So the first place I wanted to start is around the orbit or the eye. There's a variety of non-trigeminal neuralgia disorders that can happen there. The first one is something called post-herpetic neuralgia. So this is, of course, what we get the shingles vaccine for, but some patients can have a zoster reaction and get typically a rash in the affected place on their body. Sometimes it's over the trunk, but of course it can occur on the face too. And in a small percentage of patients, after they have the shingles attack, they can be left with chronic pain that's often burning. This is a really dramatic rash. This is not typical. But for patients who are left with chronic pain after shingles on the face, there's a variety of medications that can be tried. If those are not effective, I often use a technique that we'll talk about more as the talk goes on, but it's called trigeminal nerve stimulation. So this is a procedure where we insert tiny wires into the face in the area of the pain, and we target particular nerves. It's a very flexible technique. I can target just about anywhere in the face. It's not destructive, so it doesn't damage the nerves, and it's reversible. It can be turned off or removed if need be. We always trial this, so patients try this therapy for a week before ever deciding if it's something they want permanently. And for patients who have a lot of relief, which I would say is usually on the order of 85 or 90% of patients, we can then set up a time to insert a permanent system that achieves the same thing. These are wires that live under the skin. In most patients who are not very, very thin, you actually cannot see the wires, and they travel together usually to a small pacemaker that we put beneath the collarbone under the skin. As I mentioned, it's a flexible tool. We can target just about any part of the face. This is a patient I trialed extensively across different nerves. So the auriculotemporal nerve, the supraorbital nerve, the mandibular nerve, which runs along the jawline, and then the occipital nerve, which is on the back of the head. Another disorder I sometimes see is something that I'll refer to as phenopalatin neuralgia. This is pain or a headache that usually involves the upper part of the cheek, part of the eye, sometimes the nose, the forehead, and the temple. It's pretty variable. It can be intermittent or it can be constant. It usually behaves a little differently than TN in terms of the triggers. We don't really know what causes it. And typically the thing that cements the diagnosis, is that patients have a dramatic response to something called a sphenopalatine ganglion block. This is an injection of steroid or numbing medicine into part of the face to something called the sphenopalatine ganglion. It often doesn't give long-term results. It may be only a day or two, but for patients who have a really good response to that, I think about a technique called sphenopalatine ganglion or SPG radiosurgery or gamma knife. This is different than the gamma knife I mentioned before because we're targeting this ganglion and not the trigeminal nerve. Or for some patients, I consider the trigeminal nerve stimulation that we talked about before. Tolosa-Hunt syndrome is a disorder for which we typically do not do surgery. This is pain that's usually in the eye or behind the eye and can actually evolve into weakness of the eye, so difficulty in moving the eye. We don't really know what causes this. It's a form of inflammation that you can see on the MRI scan here and here. And we treat this actually with steroids rather than surgery. This is an example case of a young woman with several days of eye pain, pain with eye movements, and now loss of vision. This is another cause of orbital pain that is not treated with surgery. This is something called optic neuritis, often associated with multiple sclerosis. And again, it's treated with steroids, usually gets better on its own, and importantly, we don't do surgery for this. This is another example case. So a 50-year-old man, he has pain involving his left eye and above his eye, attacks that last usually 20 to 30 seconds. He may have 100 of them per day. And when they happen, he has some associated symptoms that I mentioned to you before. So His left nose gets congested and he has tears from his eye. His eye gets red. And so this is actually an example of a trigeminal autonomic cephalgia. This is kind of a cousin of trigeminal neuralgia. This particular form is called SUNHA. Stands for short-lasting unilateral neuralgia form headache attacks. That's a mouthful, but the characteristic of these trigeminal autonomic cephalgias is that the pain, facial pain or headache attacks are accompanied by some of those autonomic signs or symptoms that we discussed. So a red eye, tearing, maybe a droopy eyelid, a runny nose, facial flushing, and so on. Other examples are cluster headache, paroxysmal hemicrania, and hemicrania continua. In this case, these attacks are typically pretty short. This is actually one of the few pain disorders that I see that is more common in men than women. The therapy that's used for the attacks acutely when they're happening is lidocaine, IV lidocaine. And then there's a variety of medications or therapies that can be used long-term. If patients have refractory symptoms despite all those things, I consider microvascular decompression, trigeminal nerve stimulation, or that SPG radiosurgery I showed you in the last few slides. So shifting gears a bit, I want to talk about a few things that can cause pain in the ear. One of the more common forms of this is glossopharyngeal neuralgia. This is a cousin of trigeminal neuralgia. A different cranial nerve is affected, the ninth cranial nerve, also called the glossopharyngeal nerve. And patients typically get brief bouts of stabbing pain in the back of the throat, the ear, maybe the base of the tongue. It's much less common than trigeminal neuralgia, but the medications we use for it are fairly similar. This is typically caused by neurovascular compression, so a blood vessel compressing a nerve, but in this case, again, the glossopharyngeal nerve rather than the trigeminal nerve. And we have different kinds of therapy for this. Surgical therapy, one is the microvascular decompression, where we peel that artery away and in most cases actually cut the glossopharyngeal nerve. Or radiosurgery, in which case we target the glossopharyngeal nerve with the dose of radiation. Geniculate neuralgia, is a very rare form of ear pain. Very uncommon, but patients have pain generally only in the ear, not coming into the face, not going into the throat. Often is difficult to distinguish from glossopharyngeal neuralgia. The medications we use are pretty similar to those for TN, but the surgery is a little different. We actually try to identify this tiny nerve underneath the eighth cranial nerve called the nervus intermedius, and then we actually cut it. Side effects of cutting that nerve can include difficulty with tearing on that side, so your eye can become dry, and you can have a change in your sense of taste. This is a super, super uncommon disorder. Thinking about things that can cause pain in the throat, we've already talked about perhaps the most common, glossopharyngeal neuralgia, so I'll breeze through this. The other one that I sometimes see is something called Eagle syndrome. So patients with this typically describe pain on one side of the throat. Sometimes it goes down to the neck or out to the ear. And many patients describe that they feel that they have something in the back of their throat. This is due to a calcified ligament or an elongated bone called the styloid process. And we found that patients who've had a tonsillectomy in the past are at higher risk. On this CT scan, you can see this structure is very, very well. It's long. They're supposed to be shorter than 3 centimeters. This patient has quite a long one, and you can actually see it in the back of their throat. And so this is often best treated actually by an ENT doctor, removing it from the back of the throat. Alternatively, there are ways to remove it from the side of the head, as you see here. So pain that affects primarily the back of the head. There's a few things that I think about, one of which is occipital neuralgia. Patients typically describe pain that starts at the base of their head, maybe down in their neck, and then radiates up along the back of their head towards their hairline. Sometimes they're sensitive to touch in the back of their head, or touching the back of their head can trigger the pain. And we often try to start treatment with medications and then something called occipital nerve blocks. If patients don't have long-lasting relief from those, this technique that I've discussed with you guys, trigeminal nerve stimulation, I can basically apply the same thing to the occipital nerves. This is generally dramatically effective. I've seldom, if ever, seen patients who don't respond to this, and it can give profound and long-lasting relief. Another thing that causes pain or headaches at the back of the head is something called a Chiari malformation. This is a disorder in which part of the brain called the cerebellar tonsils lies a little bit lower in the skull than it's supposed to. Usually the tonsils are supposed to end at or above this red line that you see here. And so there's a procedure called a Chiari decompression where we can remove some of the bone at the base of the skull to try to give that tonsil a little more space so that it's not compressing the back of the brainstem. This is an example case that I treated, a patient who had actually a fairly modest Chiari malformation, but had developed this large syrinx or enlarged fluid cavity in her spinal cord as a result. And you can see that a few months after treating the Chiari, opening up the space back here, the syrinx has shrunk considerably. So a few more things that I wanted to review that can cause pain over the cheek and the jaw. So this is the same area that we think about the typical pain of trigeminal neuralgia. I'll do this by way of a few example cases. So the first is a 66-year-old woman. She'd been taking Tegretol for many years for what was being
doing
called
a Zoom
neuralgia.
thing
Um,
on
and
trigeminal.
now she
Oh,
has
well,
both the intermittent
wanted
attacks
to
of
see
pain
if
you
as
blew.
well as
Yeah.
constant pain over her cheek and jaw.
It looks nice.
I think somebody might not be muted.
Yes, Cindy.
So this is a disorder that is actually a variant of trigeminal neuralgia called type 2 trigeminal neuralgia. And what it means is basically that patients can have some of the typical pain of trigeminal neuralgia, but now they have more or less constant pain in between the attacks. So their pain is no longer episodic. It's occurring all the time. We often think of it as a consequence of long-term untreated trigeminal neuralgia, but I've met patients who have type 2 TN who never had the intermittent lightning zaps in their face. And the way we treat it is very similar to the way we treat traditional type 1 trigeminal neuralgia. So here's another example. This is a 68-year-old man, a history of right V2, V3 trigeminal neuralgia. So again, the lower part of his face. He previously had gamma knife. It was well controlled for years, and now he's presenting with an excruciating recurrence over the past few weeks that's kind of reaching a crescendo. He has constant pain that's so bad that all of a sudden, out of the blue, he's no longer able to eat or drink. This is something I call status trigeminus. And really what it is a crescendo of TN symptoms, often without explanation. The attacks of TN increase in severity and frequency until a patient basically has constant pain. And this can evolve pretty quickly. And in severe cases, the pain can actually interfere with staying hydrated. And as a result, this can become an emergency situation that sometimes requires hospital admission. We treat this with hydration, with IV medications, and then consideration of surgery, although it's usually not needed urgently. If surgery is needed, I'll typically perform one of the percutaneous rhizotomy procedures that we discussed before. Another example, this is a 54-year-old woman. She has a history of dental and sinus surgery and now has constant burning pain over her upper cheek. She's seen her dentist and her ENT, and they haven't found any problems. This is something I encounter fairly commonly, and I call it trigeminal neuropathic pain. We think this develops due to injury or damage of the trigeminal nerve pathway. And the characteristic is that patients have constant or burning pain and usually did not have typical symptoms of TN before that. There's a variety of causes of this. I've listed some of them there, but actually in most cases, I think we don't really identify a cause. And the key here is that the traditional procedures for trigeminal neuralgia, particularly those that are damaging to the trigeminal nerve, may not be effective and actually risk making things worse. And so it's important to avoid them. I rely really heavily on a technique that we've already discussed, trigeminal nerve stimulation for treating this. And as I said, the responses to this disorder, which is often underdiagnosed or mislabeled or waved away, which I think is unfortunate. The responses to this kind of therapy are typically dramatic. One other disorder I wanted to mention is something called anesthesia dolorosa. This is a really feared complication for surgeons of some of the procedures we've talked about for TN. Essentially what it is a very painful area of the face that's also numb. And this is one of the dangers of doing repeated destructive procedures on the nerve. And this is why I will never cut one of the branches of the trigeminal nerve, for example, is because you take a risk of causing something like this. And if it does happen, you have to basically try to focus the treatment on something higher up in the nervous system than the nerve that's affected. So the spinal cord or the brain. One example of treatment that can be used in that circumstance is spinal cord stimulation. This is something I actually use quite a bit for other forms of pain in the neck or the back or the arms or the legs. But you can do analogous things to try to treat pain in the face. Results are a little bit more mixed, and it's definitely much more effective for pain in the lower face than pain in the upper face, but it is one kind of bailout or salvage technique that can be used for patients with this difficult problem. And then finally, there's this other diagnosis that I try not to use, I don't like to use. It's something called atypical facial pain. I think this diagnosis is used a lot inappropriately, but the way I think about atypical facial pain is really pain that doesn't respect a particular nerve distribution. It may shift around in the face at different times. It may involve the shoulder or the neck. It's strongly correlated with psychological disorders, including depression. And generally, we try to avoid surgery for patients affected by this. It's a difficult problem. But again, I think many patients who actually have forms of trigeminal neuropathic pain or some of the other diseases that we've talked about get mislabeled with this diagnosis. Just a couple mimics of trigeminal neuralgia that can cause pain involving the whole head or half of the head. One of these is something that's fairly pedestrian, fairly common. Migraine, there are certain forms of migraine that can be very chronic and can occur very frequently or can be almost constant. Historically, we haven't thought about surgery for chronic migraine, but there's emerging evidence, and I've had good anecdotal results with the forms of neuromodulation or stimulation that we've talked about. So a common thing that we'll try is stimulation of both the supraorbital nerves in the front of the head and the occipital nerves in the back of the head. And I have several patients who've had very profound relief from their chronic migraines from an approach like this. So I wanted to leave time for questions, so I'm going to wrap up and kind of summarize things again. This is the same slide, I think, that I showed at the beginning. Again, most of these diagnoses are based simply on history, what you described to me, and I seldom have reliable blood tests or scans that will distinguish one of these disorders from the other. And so I think it's really important to keep a diligent record of your symptoms. Some of these disorders, as you've seen, are very similar to one another, and the symptoms can overlap. But importantly, as you've seen, not all facial pain is trigeminal neuralgia. Trying to get the correct diagnosis is critical because the treatments can be quite different. And some of them, if we choose incorrectly, can even make the pain worse. And again, many of these forms of facial pain are effectively curable. And so be your own advocate, keep records, and find somebody who's dedicated their career to this and has a sincere interest in treating facial pain. I'm going to make another quick plug for the website. So this is something created and curated by me. I have pages on lots of the different facial pain disorders that we've discussed, including patient-friendly descriptions, sometimes in a Q&A format like you see here. And then also descriptions and in some cases, videos of some of the surgeries that we've talked about. So with that, I'll wrap up. And at this point, I'm happy to take any questions that you guys might have.
I'm going to go ahead and stop the recording now.
Sure.